Hello my juniors, welcome to another anatomy lecture series. Today is your great science Lorenzo, and today we'll be talking about the hip joint. So I've talked to you the joint of the upper limb, which is the shoulder, the elbow, and the wrist joint. So today we'll be doing the joint of the lower limb, which is the hip, knee, ankle, and we'll be doing the TMJ, which is the temporomandibular joint. So these are the joint series which are important for your MBBS XA, your BDS, your MCAT exams, your USLMA. We'll be doing more of the clinical version later. Be asking you questions, MCQ questions that are USMLA inclined, and other Huskies exams and other important exams that are medical inclined for those that are writing it. So we'll be giving important tips at the end for those writing those exams, and I'll tell you take some important notes on the question in case they ask you for your exams too. So if you are new to my channel, make sure to subscribe and turn on your post notification button so at any time I drop any video you'll be sure to be notified. If you want me to make a video for you, drop it down in the comment section. I promise I'll make the video for you and you understand very well. So let us jump right into the video. So we'll be using some useful outlines here to talk about the hip joint. It's very important. So the first one we'll be talking about is to introduce the hip joint. Is very important. Let us introduce what the hip joint is. So number one, the hip joint is an articulating joint between the head of the femur and the acetabulum of the hip bone. Again, it is between the head of the femur and the acetabulum of the hip bone, or which you say it is between the femur and the hip. Are you getting now? Between the femur and the hip. That is number one. It is the strongest weight-bearing synovial joint. Are you getting me? Because it bears the weight of the trunk. The trunk is resting on it, so it bears the weight of the trunk. So it is the strongest weight-bearing synovial joint that transmits the weight of the trunk to the lower limb during standing and walking. So when you are standing, what happens? Your trunk, which is your abdominal part, your pelvic part, your upper side of your body, is resting on the hip joint. So it is transmitting that weight from your trunk to your lower limb when you stand and when you run. Because when you are running, it is also your hip that carries you while you do your motion. So it bears the weight and transfers it from the upper trunk, which is the limbs, the head, the chest, the abdomen, the pelvic, down to the lower limb. So it transmits it. So take note, between the head of the femur and the acetabulum of the hip bone. 2, it is a weight-bearing synovial joint that transmits force or shear force between the trunk and the lower limb during standing and walking. It is the most stable joint in the body while still permitting wide range of motion. So it permits every range of motion, just like the shoulder joint. So it is the same joint. Are you getting me now? So I've introduced what the joint is, very important. And also you have to know what are the key features. Number one is a strong weight-bearing joint. It connects the lower limb with the axial skeleton. So what is your axial skeleton? Your axial skeleton is your upper limb, your thorax, your abdomen. These are your axia, and you have your appendicular, which is your pelvic down to your lower limb. So it connects the axial skeleton with the lower limb. It permits wide range of motion. Always remember, because you can do all the 6 range of motion you can do for your shoulder on the hip joint, and also it maintains stability during running and standing. So the next is the type. So what is the type of the hip joint? It is a synovial joint of a ball and socket variety, because under the synovial joint you have different types. You have the ball and socket joint, you have the hinge joint, you have the pivot joint, you have the plane joint. So go watch my video on what classification of joints. So under the classification you have the fibrous, you have the cartilaginous, and you have the synovial. So your hip joint is under the ball and socket joint of a synovial variety, so it is inside the synovial joint. We call it the multi-axial joint. Are you getting me? Because it can perform various range of motion. So various range of motion is possible here, which is flexion, extension, lateral and medial rotation, abduction and adduction. So it's a multi-axial joint, which means various range of motion can occur in this joint. So what is the articulating surface? So you can see what is shining here, because that's why I put the pictures for you. So what is the articulating surface? The articulating surface is between the hemispherical head of the femur, the hemispherical head. So you can see the head of the femur, hemispherical. The hemispherical head of the femur. Are you getting me now? With the acetabulum of the hip bone. Are you getting me now? So the articulating surface is the articulating surface of the hemispherical head of the femur and the articulating surface of the acetabulum of the hip bone. So that is this shiny surface are coming together. So which means the acetabulum of the hip bone is a lunate surface. We call it the horseshoe shape. It's like a horseshoe, the hoof of a horse. So it's a horseshoe shape which is lunate, which you call the acetabulum of the hip bone, which comes together with the hemispherical head of the what? Femur. Are you getting me now? So it's very, very important for you to know that very well. As now they are lined by what we call hyaline cartilage. They are covered by hyaline cartilage, except for the fovea capitalis. So the fovea capitalis is the part whereby located usually the tip. Don't mind this diagram. Are you getting me? I don't mind this diagram. So this diagram, the fovea capitalis is usually at the head, the tip of the femur. Are you getting me? At the tip of the hemispherical head of the femur, it transmits blood vessels that moves, which is your reticular vessels that moves through the bones, because your medial circumflex femoral artery gives reticular arteries which enters to the neck of the femur down to the fovea capitalis. So the fovea capitalis do not have cartilages. In the humerus, there is a glenoid labrum which deepens the hemispherical head of the humerus into the glenoid cavity of the scapula to provide stability. Same for the femur too. There is a acetabulum labrum. There's a labrum here which deepens the hemispherical head of the femur into the acetabulum of the hip bone. This helps to provide stability. And again, it's lined by hyaline cartilage except from the fovea capitalis. So the next we have done the introduction, we have done the type, we have done the articulating surface. Now we're in the capsule now. So what is the joint capsule, or we can call it the fibrous capsule? The joint capsule of the fibrous capsule is a non-collagenous dense connective tissue. Are you getting now? So it's a non-collagenous dense connective tissue that covers the surface of the joint. It is tough and it bends with the surrounding ligament. Are you getting me now? So proximally, look at the proximal origin of it, or the proximal attachment. You see the margin of the acetabulum. Are you getting me now? So it's coming from the margin of the acetabulum and the transverse acetabular ligament. So it blends with the transverse acetabular ligament superiorly, and also the margin of the acetabulum, and below it attaches distally to the intertrochanteric line anteriorly and the femoral neck posteriorly. Okay, now so it is attaching anteriorly with the intertrochanteric line and the femoral neck posteriorly. That is the distal attachment, while the proximal attachment is the margin of the acetabulum, which you are seeing here, and it also blends with the transverse acetabular ligament. Okay, so it's immediately after you have the joint formed, the first thing that is covering the joint is the fibrous capsule, or you can call it the joint capsule, anyone you want. So since you have understood this part now, the next thing here is that the important thing you have to note for each one. So every outline has an important thing to note. So what is the important thing to note here? The capsule is attached above by the acetabulum and below by the femur. So it's just like it's a reinforcement. It's just helping you to cover the joint first. So the first covering of every joint is the fibrous capsule. So it's attached above by the acetabulum and below by the femur. It is thick, strong, and fibrous, and it's a non-collagenous dense connective tissue that covers the surface of the joint. Are you getting now? It is deficient anteriorly, where the iliofemoral ligament is present. So there is no fibrous capsule anteriorly. Why? Because the iliofemoral ligament is covering it anteriorly, but there's a fibrous capsule posteriorly. Even though the ischiofemoral is there, but there's also a fibrous capsule posteriorly, but it is deficient anteriorly because of the iliofemoral ligament. So the next one we're talking about is synovial membrane. So what is the synovial membrane? So the synovial membrane lines the inner surface of the fibrous capsule. So you remember I say when the two bones join together, which is the articulating surface join together, are you getting me now? They are covered by a fibrous capsule. So inside that fibrous capsule, it is lined by what we call a synovial membrane. The synovial membrane does secrete synovial fluid. So a synovial fluid is an extracellular fluid. Is a very, very important fluid that helps to lubricate and prevent friction between joints. Are you getting me now? So when there's movement, it's just like a moving part. There will always be a friction. When the bones are moving, there should be a friction. But what does the synovial fluid do? The synovial fluid prevents that friction from occurring by increasing fluidity between the joints, increasing joint nutrition, helping the bones and not to corrode. Are you getting me now? Very, very important. Here, the function here is to secrete synovial fluid, two, to lubricate the joint, to nourish the articulating cartilage. Why? Because if not, they will start corroding, and that's what causes what osteoarthritis and rheumatoid arthritis and some pathology that occurs in the knee due to the reduced joint nutrition. So joint nutrition helps to lubricate the bones, the cartilage themselves, and to make them continue walking without wearing and tearing. Also, it reduces friction during walking. So the key thing to note is that the synovial membrane is vascular, which means they are supplied by blood vessel, because this membrane has what we call extracellular fluid, and extracellular fluid is usually the blood. So they are supplied by blood very well. That is why sometimes during synovitis, when there's inflammation of the synovial membrane, there will be increase in synovial fluid. So there will be a lot of synovial fluid production. Are you getting me now? So this a lot of synovial fluid that is occurring causes what? Swelling in the joint. So it's very, very bad. Also, it is not present on the articulating cartilage. So there's no synovial fluid on the articulating cartilage. So very, very important for you to know that. So it is highly vascularized. And since it's highly vascularized, the next thing here is that it is not present in the articulating cartilage. Are you getting me now? And also it forms folds on some areas. So some areas is formed double folds. Are you getting now? So you can see the diagram, the schematic diagram of a synovial membrane, and you can see the fluid that is helping movement very, very efficient. So we have talked about the introduction, the type, articulating surface, fibrous capsule, synovial membrane. So the next one I'll be talking about is the ligament. Are you getting now? So we have some ligament to be talking about. So there is an extracapsular ligament and an intercapsular ligament. So but we'll be talking about all of them together, and I'll tell you which one is extracapsular and there's which one is what? Intracapsular. First of all, we have the outside one, which is the extracapsular ligament, which is very, very visible. So we have the iliofemoral ligament, by the name iliofemoral ligament. You are looking at this ligament here, iliofemoral ligament. The iliofemoral ligament, just like you know, it is attached proximally by the anterior inferior iliac spine. The ASA is attached to the anterior inferior iliac spine. Are you getting me now? And also the acetabular rim. Yeah, the anterior inferior iliac spine and the acetabular rim, which you are seeing, and inserting in the intertrochanteric line of the femur. It's coming from the ICs, which is the anterior inferior iliac spine. Are you getting me now? And inserting in the intertrochanteric line of the femur. Very, very important. It is the strongest ligament in the body. Put that in the bank. It is very, very important to know. It is the strongest ligament in the body, and it prevents hyperextension of the joint. So remember, the quadriceps femoris helps in extension of the knee. So what prevent excess extension of the knee? It is the iliofemoral ligament. So it prevent hyperextension of the knee and also help to make erect posture during standing with minimal muscular effort. So when you are standing over a long period of time, your iliofemoral ligament, which is the strongest ligament in the body, helps you prevent extension and to make you erect while you're standing. So when there's a damage to this one, you'll be having general reconverticum, and also there will be hyperextension of the knee. Are you getting me now? Usually seen in general reconverticum patients. There's pubofemoral. So just like the name, iliofemoral from the ilium, which is which part of the ilium? The anterior inferior iliac spine, and also the acetabular rim. But for the pubofemoral, pubo means from the pubics, but which part of the pubics? You see now from the superior pubic ramus and the obturator crest. From the superior pubic ramus and the obturator crest. So that is where it is coming from, and it's inserting with what? By blending with the inferior part of the capsule and also the iliofemoral. So it blends with the iliofemoral and also the inferior part of the fibrous capsule of the joint. So it's coming from the superior oblique ramus and also the obturator crest, and it's inserting by blending with the inferior part of the joint capsule and also the iliofemoral ligament. So what does the joint do? It prevent what? Excess abduction. Why the iliofemoral prevent excess extension? This one prevent excess abduction, and it reinforces the inferior aspect of the capsule. Like I said, it blends with the capsule. So since it blends with the capsule, it reinforces the capsule, preventing and protecting them more and more. You get it now? So that is the reason why we say after the fibrous capsule is the ligament. So the ligament just helps by attaching on top of the capsule to all help reinforce them and increase stability. So we have talked about iliofemoral, we talked about pubofemoral from the pubic ramus and the obturator crest. Now we are talking about ischiofemoral. So the ischiofemoral is coming from the ischial part of the what? Acetabular rim. You are seeing the ischial part of the acetabular rim by the picture there, and it's inserting on the greater trochanter and the femoral neck. So you see the greater trochanter there, and you can see the femoral neck. So it's inserting on the greater trochanter and the femoral neck, coming from the ischial part of the acetabular rim. Are you getting me now? So it is one of the weakest ligaments of this of the hip joint, but it prevents excess what? Medial rotation. As pubofemoral prevent excess abduction, and iliofemoral prevent excess extension. This one prevent excess medial rotation, and also reinforce the posterior part of the fibrous capsule. So it covers the posterior side, also reinforcing them to prevent what? Damage, or to prevent the capsule from tearing out. Are you getting now? So we have talked about ilio, pubo, and ischio. The next one is transverse acetabular ligament. We have the transverse acetabular ligament. So the transverse acetabular ligament, they bridge the notch. Are you getting now? They bridge the acetabulum notch. So you can see the hole there you are seeing in the joint. So that hole you are seeing in the acetabulum is called the acetabulum notch. The acetabulum notch there, the transverse acetabulum ligament bridges that notch, convert it into a what? Foramen. So it bridges the notch and convert it to a foramen. So this foramen allows for the passage of blood vessels and nerves that comes from the what? Fovea capitalis, enters into the joint. So the blood supply, which is the medial circumflex femoral that gives reticular branches or acetabulum branches, passes through this part of the joint and enters into the transverse acetabulum what? Canal. So it enters into the acetabulum canal. Remember, it was acetabulum notch in that forms acetabulum foramen or canal. When the transverse acetabulum this bridge through it. You get it now? So very important. So now what does it do? Remember, it allows for the passage of what? Blood vessels and nerves, and also complete the acetabulum what? Rim. So it bridges the acetabulum notch. So you can see what the notch is. There are two holes that are open. That is acetabulum notch there. So that's it. So the next one is acetabulum labrum. So what is acetabulum labrum? Remember, the acetabulum labrum is dipping the hemispherical head of the femur into the what? Acetabulum of the hip. So here now it is attaching to the what? Acetabulum margin. So you can see the acetabulum margin there is attaching to the acetabulum margin down to the what? Down to the what? Anteriorly by the intertrochanteric line and posteriorly by the what? Femoral neck. So it's attaching there. It deepens the acetabulum by dipping the what? Femoral head into the acetabulum of the hip. It increases stability by deepening the what? Head down to the neck. Are you getting that? Down to the neck, so that the hip joint can be stable and the head can be intracapsular inside the hip joint very well. It also maintains negative interarticular pressure. So it acts as a shock absorber, also maintaining what? Interarticular pressure. So at excess pressure, it comes out, it goes in. So it just helps you to maintain your balance. Also, you have the ligament of the head of the femur, which is the ligamentous teres too. So in the ligament of the head of the femur, where is it coming from? It is coming from the what? Fovea capitalis. Are you getting me now? The fovea capitalis, remember, that is at the tip of the what? The hemispherical head of the femur. That head at the tip, you see the fovea capitalis. So it begins from the fovea capitalis and what? It goes down to the acetabulum notch. Are you getting me now? So it leaves from the fovea capitalis, attached to the acetabulum notch and the transverse acetabulum what? Ligament. Because through this fovea capitalis, which is the ligament of the head of the femur, here you pass what? Acetabulum branches of the obturator artery to the head of the femur. Because here, like I said, the what? Acetabulum branch of the obturator artery passes through the fovea capitalis to enter into the what? Acetabulum foramen. So what causes So what forms the acetabulum foramen? The acetabulum foramen is formed when the transverse acetabulum ligament bridges the what acetabulum notch. So when they bridge it, the fovea capitalis, and which is the ligament of the head of the femur, I get him now. The ligament of the head of the femur begins from this fovea capitalis and blends with the transverse acetabulum ligament. From here, blood vessels can move from this fovea capitalis down to that what acetabulum what foramen. So it has a minor stability role. This ligament do not help in stability, so just help to transmit blood supply to this area. And it's also important blood supply to the what femoral head during childhood, because I tell you there are reticular fibers which are coming from the circumflex femoral vessel, which supplies the neck of the femur. So during femoral neck fracture, it could also causes a vascular necrosis, damaging those blood vessels around that area. So the next thing is the bursa of the hip joint. So what are the bursa of the hip joint? So the bursa are a small synovial fluid filled sac. Are you getting now? So they are small synovial fluid filled sac that reduce friction between the bones, muscles, and tendons. So they are tiny spaces. They are just tiny spaces which are small synovial fluid filled sac, which are not part of the joint but just blends under muscles, under bones, like between muscles and bones. They are just small synovial fluid spaces where synovial sacs accumulate synovial fluid, which is not inside the joint but around the joint. You get it now? You just protect muscles against bones and the effect of bones against themselves, and just helps you shield you from many things. But one particular problem is that most of them can get inflamed, causing what? Bursitis. So what are the bursas in the hip joint? You have the trochanteric bursas, you have the ischial bursas, you have the glutofemoral bursas, you have the iliopsoas bursa. Now in the trochanteric bursa, it is located between the gluteus maximus and the greater trochanter. That is where you can see the trochanteric bursa. So you can see it between the gluteus maximus and the what? Greater trochanter. It reduces friction between the gluteus maximus and the greater trochanter during movement. So you have trochanteric bursa, you have the ischial bursa. The ischial bursa is between the gluteus maximus and the ischial tuberosity. Are you getting me? So also reduce friction between those two parts, the gluteus maximus and the ischial tuberosity. So the next one is the gluteofemoral bursa. So what is the gluteofemoral bursa? It's between the gluteus maximus and the versus what? Lateralis. Are you getting me now? The versus what? Lateralis. So one thing you have to understand now, that the versus lateralis is a part of the what? The quadriceps femoris, because the quadriceps femoris have 4 muscles, which is the vastus medialis, lateralis, intermedius, and rectus femoris. So between the gluteus maximus and the vastus lateralis is the gluteofemoral what? Bursa. It allows smooth movement and gliding between the gluteus maximus and the what? Vastus lateralis. So we have talked about the trochanteric bursa, the ischial bursa, the gluteofemoral bursa, and the ischio-psoas bursa. What is the iliopsoas bursa? The iliopsoas bursa is between the iliopsoas muscle and the what? Hip capsule. I get it now. Between the fibrous capsule of the hip and the iliopsoas, there's a space there called the iliopsoas or subpsoas bursa. Subpsoas means it's under the psoas major muscle. So between the iliopsoas and the what? Joint capsule, there's also a bursa there which prevents friction between the iliopsoas tendon and the capsule during flexion of the hip. So because iliopsoas muscle is the chief flexion of the what? Hip joint. So during flexion of the hip joint, the iliopsoas muscle is safe on the hip capsule because of that bursa, to help and prevent damage during flexion. Are you getting me now? So we have talked about the ligament and the bursa of the hip joint. So the next is the relation of the hip joint. The first one we'll be talking about is the anterior relation of the hip joint. Why? Because the relation means what are the vessels, what are the organs, what are things that are related, what are the muscles, the nerves, the blood vessels that are related to the hip joint, anteriorly, posteriorly, laterally, everywhere. So the first one is the anteriorly. Now what structures are located anteriorly? So we have the iliopsoas. Iliopsoas means the iliacus and the psoas major. because the iliopsoas, the iliac is coming from the what? Iliac fossa, while the psoas major is coming from the what? Lumbar vertebrae. So when they come together, they fuse and insert on the lesser what? Trochanter. So first of all, they pass through that area. That is the number one. You have the femoral nerve, femoral artery, femoral veins. These are neuromuscular. These are neurovascular structures that passes in front, and also you have the pectineus muscle. So the pectineus muscle is the muscles of the medial compartment of the thigh. Also you have the rectus femoris too. All these muscles are anteriorly related. So the next one, which muscles are posteriorly related now? Remember, for posterior we have the gluteal muscle. All the gluteal muscles are posteriorly related, while the muscle and the neurovascular structures in the anterior compartment of the thigh is anteriorly, while the gluteal muscles are posteriorly now due to their orientation. So we have, first of all, we have the piriformis. The piriformis is the first deep muscles of the gluteal region. You have the obturator internus, you have the gemellus superior and inferior. All these are deep muscles. You have the quadratus femoris. So all these 5 muscles we just mentioned are deep muscles of the gluteal region. Also we have the sciatic nerve. We have the superior gluteal and inferior gluteal vessels and nerves. So all these are related to the posterior relation of the hip joint. Are you getting me now? So we have superiorly. So what are related superiorly to the hip joint? So you have the gluteus minimus and medius, and also the reflected head of the rectus femoris. So you see, so we have the straight head of the rectus femoris and the reflected head of the rectus femoris. The reflected head of the rectus femoris is superiorly, while the straight head is what? Anteriorly. So this relation superiorly is the gluteus minimus, medius, and the reflected head of the rectus femoris. Inferiorly. So what is related inferiorly? For inferiorly, you have the pectineus and the obturator externus. These are muscles of the medial compartment of the thigh. So we have talked about the relation of the hip joint. So next we'll be going to is the movement of the hip joint. So you have to remember and you have to know these muscles very, very well. For flexion, what flexes the hip joint? So what flexes it? So remember what we call SA. So SA muscle is a very, very important muscle that you can remember. So there are some muscles too, but remember the word SA. So SA muscles usually they are the chief flexure of the hip joint. So what is SA? We have the sartorius. Are you getting me now? We have the iliopsoas, which is the chief flexure. So always remember the chief flexure is the iliopsoas. But you have the sartorius, you have the iliopsoas, and you have the rectus femoris. These are the 3 basic muscles that flexes the hip joint. So the pectineus also can assist in flexion of the hip joint because it has dual nerve supply. It has the femoral nerve and is supplied by obturator nerve. So the 3 chief muscles here is sartorius, iliopsoas, and rectus femoris. Tensor facial lateral and pectineus can assist, but majorly there are no texts that I just added there because it's very, very important. You can see it in your text. For extension means that they are moving the thigh backward in the sagittal plane like this in diagram you are seeing here. So which muscles help me in extension? So number 1, you have the gluteus maximus, very, very important. It helps you in extension. It's the chief extensor. So you have the gluteus maximus who also help you. You have the semitendinous, you have the semimembranosus, you have the long head of the bicep femoris, because the hamstring muscle, you get them now, extend the hip joint. They extend the hip joint and they flex the knee joint. So the hamstring muscle help you to extend the hip, while the chief muscle there is the gluteus maximus. For abduction, abduction. So who does abduction? By now taking the hip away from the midline plane. So help us to do that. You have the gluteus medius, which is the chief abductor. You have gluteus medius, you have gluteus minimus, you have tensor facial lata. Gluteus medius, gluteus minimus, tensor facial lata, and also sartorius can also assist. So sartorius helps, they call it the tailor muscle. Why did they call it the tailor muscle? Because it helps you to flex the hip and flex the knee and also assist in abduction. You get it now? So gluteus medius is the chief abductor together with the minimus and the tensor facial lata. to take the hip now back to the median position, because it was away, now to take it median position, just like you're marching like a soldier. So which muscle can you use now? You can use your abductor muscles in your medial compartment of your thigh. So who are your abductor muscles? You have your abductor longus, you have the abductor brevis, you have the gracialis, you have the pectineus, you have the abductor magnus. So these are muscles of the medial compartment. They help you to bring your limb back. You have medial rotation. Medial rotation is rotating the leg medially. You are just rotating it medially. So who help us to rotate it medially? Are you getting now? So medially, the medial rotator are what? You have the gluteus medius, gluteus minimus, and facial lateral. So these are the chief medial rotator of the what? Hip. Gluteus medius, gluteus minimus, and facial lateral. And these three people also help in what? Abduction of the what? Hip. So who does lateral rotation? Lateral rotation is rotating the leg laterally too. So all the deep muscles of the gluteal region helps in lateral rotation. The piriformis, obturator internus, externus, gemellus, superior, inferior. You have the quadratus femoris, not quadriceps femoris, and also you also have the gluteus maximus. So the gluteus maximus can also assist in lateral rotation, but the chief lateral rotator are muscles of the deep compartment of the gluteal region. So in circumduction is just like combining all the motion together in a circular plane. So for the flexion, you have the psoas muscles, which is your sartorius, iliopsoas, rectus femoris. For your extension, you have the gluteal muscles and your hamstring, which is the gluteus maximus, semitendinous, semipimenosus, and bicep, long head of bicep femoris. Abduction is by what? The gluteus minimus, medius, facial lateral. I get him now. The adduction is the adductor muscles of the medial compartment. Medial rotation, the same people that does abduction does medial rotation, which is the minimus, medius, facial lateral. Lateral rotation are the deep muscles of the gluteal region. Circumduction is combining all of them together. So what are the blood supply here? So the blood supply to the hip joint is very, very simple. So the obturator arteries also give a branch here, obturator artery. You also have the medial circumflex femoral and lateral circumflex femoral. Medial circumflex femoral supply the bones. Are you getting me now? To what we call the reticular fibers. So you give reticular fibers and supply the neck down to the head. You get it now? So, but usually it is the ascending branch that give what we call trochanteric anastomosis. So usually the trochanteric anastomosis, not really the trochanteric anastomosis, but at this particular point, the ascending fiber, are you getting me now, of the what? Lateral and medial circumflex femoral. Are you getting me now? You also have the acetabulum branch of the obturator artery. Are you getting me now? So you have the acetabulum branch and the posterior branch of the medial and lateral circumflex femoral. Of this one donates, so three branches that forms a circle. You have the obturator artery, the acetabulum branch, you have the medial and lateral circumflex femoral. So these three, so basically it's the obturator artery and the femoral artery that gives blood supply to the hip joint, because any artery that passes through a joint will give a supply to the joint. Nerve supply. So again, the same thing, any nerve that passes through a joint will give a supply to the joint. You get it? So what are the nerve supply that passes through this joint? Let us look at them. You have the femoral nerve, yes, passes through because you supply the anterior compartment of the thigh. Femoral nerve, which is the largest branch of the lumbar plexus. Femoral nerve, you have the obturator nerve, which is the dorsal branch, L to L4. The accessory obturator nerve also passes here to supply the medial compartment, the pectineus. Also give it. Superior gluteal nerve too. Superior gluteal nerve supply the gluteal muscle, also give a branch too. Are you getting now? Then also we have the inferior gluteal muscle too, the same thing here. So the inferior gluteal muscle also passes through there and also give a branch there too. Then you have the nerve to the quadratus femoris. The nerve to quadratus femoris is a nerve that supplies the quadratus femoris muscle, which is a muscle of the deep compartment of the gluteal region, also supplies it. Also, you have the sciatic nerve. The sciatic nerve passes through the landmark between the greater trochanter and the ischial tuberosity, which is another landmark. Also, it passes through the gluteal region and also gives supply to the joint also. So all this that is just saying that any nerve that passes through that joint will give a supply to the joint based on Helton's law. So these are all the whole joint that passes through that region, giving a supply to the joints also. Also, the key note you have to know that these nerves carry pain fibers also. So pain fibers are carried by this nerve also, very very important. And also pain often are referred to the knee. Are you getting me now? So pain from here are referred to the knee and to the buttock and the thigh. So due to the distribution of this nerve, any pain that you are seeing here are what carried out in various directions along the distribution of the nerve. So the next one, stability. Get it now? So the next one is stability. So what is stability here? Are you getting me now? So the stability of the joint is due to how the joints are orientated, or how the structures that cover and protect the joints are orientated in such a way as to keep the joint fixed. Are you getting me now? And prevent what damage due to dislocation or fracture. Are you getting me now? So the stability of it is due to the what? Deep socket, the strong capsule, the ligament, the surrounding muscle, all the structures that are just all around the joint. Because as far as these structures are concerned, as far as they are there, they have to give what we call stability to this joint and allow the joint to be stable and prevent what fracture or what dislocation. Are you seeing now? So the first factor I want to talk about here is the bony factor. So the bony factor also helps in stability. The deep acetabulum covers about 2/3 of the head of the femur. So the acetabulum is so deep that it already covers 2/3 of the femur. I get him now. And also we have the acetabulum labrum here, which is also attached to the acetabulum margin of the bone, that also helps to bring stability. We also have the capsule and the ligamentous factor. Remember, there's also a joint capsule. The joint capsule there, or they call it the fibrous capsule, is a non-collagenous dense connective tissue that also protects the joint from outside, reinforcing it and increasing stability. We also have ligaments, like the strongest ligament, the iliofemoral, the pubo, and the ischiofemoral. I get them now. They prevent excess movement like extension, abduction, and medial rotation. Muscular factor. So the muscular factor here is that there are so many powerful muscles that pass through these joints, front and back. The gluteal muscle at the back, the medial compartment muscle are in the middle, and the anterior compartment, which is the femoral muscle, too, are in front. So all these muscles stabilizes the joints. So especially the gluteal muscle at the back, they are the chief stabilizer of this joint. I get them now. Also the interarticular factor. There's negative articular pressure. I get them now, which gives a suction effect. Yeah, there's a negative interarticular pressure which gives a suction effect. Not that the joint is tightly on the bone, not that the joint, both of them, there's a space there which causes the negative interarticular pressure. That's why the synovial fluid can easily drain into the venous supply. I get them now. So it's very very easy. And also there's lubrication by synovial fluid, which helps to reduce friction. Also ligament of the minor of femur is also ligament of the head of the femur gives a minor role in also stability. So we have talked about blood supply, nerve supply, we have talked about stability. So we are ending it with clinical correlation. Here. So now one thing you have to understand, under the clinical correlation here, we have what? Congenital dislocation. In congenital dislocation, we call it what? Developmental dysplasia of the hip. So you see what the normal hip is, and you see what the congenital hip is. So why do we call it congenital? Because the formation of the hip wasn't complete during birth. Here there's shallow acetabulum. Which means the acetabulum here is not covering 2/3 of the hemispherical head of the femur. So there's shallow acetabulum. There's lax ligament, which means the ligaments here are not strong, which lead to a dislocation of the head of the femur. Now the head of the femur can easily pull out from the acetabulum because it is not deep, it is not intercapsular. It is common in female and the firstborn children. So it's common in female. This congenital dysplasia, or we call it congenital dislocation, is when the acetabulum is not deep into the part that the head of the femur can be so impressed into it, preventing dislocation. So it's common in female and in firstborn, and its present will limit what abduction and causing asymmetrical skin fold around that area. So how will you know? By doing your physical examination, you see an asymmetrical skin fold around that area. Early diagnosis and management are very, very important, and also much of physical therapy is also very, very important. Okay, now so we have done congenital dislocation or developmental dysplasia of the hip. So the next one is what? Acquired dislocation. So what's acquired dislocation? This one is not congenital. So where is dislocation more common? So there's more dislocation at the posterior part of the hip. So the posterior part of the hip is where dislocation occur because the ischio-femoral ligament is not strong. But the anterior is not possible in anterior because the iliofemoral ligament is the strongest ligament. So it's not possible anterior, but it's possible posterior. And the ischio-femoral prevent what? Medial rotation. Yeah, so usually due to road traffic accident, even though they want to be pull up, maybe the head of the femur want to pull out, is usually pulled out posteriorly, where the limb is flexed, adducted, and medial rotated. And when there's medial rotation, excessive medial rotation, the ischio-femoral ligament has to help to prevent the joints from being loose, but here it could not help. Also, anterior dislocation is when it is abducted and external rotated, but anterior dislocation is rare. The next one is what? Fracture of the neck of the femur. In the fracture of the neck of the femur is when the neck of the femur, because the neck of the femur is more longer, so it could be at the subscapular fracture where a fracture below the head of the femur. It could be transcervical fracture, it could be basicervical fracture at the base of the neck of the femur, depending. It could be trochanteric fracture. I get him now. It could be basal fracture. It could be any type of fracture. So we have basal fracture, we have subcapital fracture, we have trochanteric fracture. I get him now. We have intratrochanteric fracture. Now remember, I said that blood vessels, the medial circumflex femoral, give blood vessels through the neck here. I told you in the beginning, we call it reticular vessel. So when you give blood supply and here the neck of the femur fracture, remember what happens. There will be risk of avascular necrosis. Avascular necrosis in the sense that avascular, which means no blood, that the bone will start dying. It's more usually common in osteoporotic patients. Are you getting me now? When they fall, are you getting me now? They fall and they break their what? Greater what? Trochanter. Are you getting me now? So when there's fall on the greater trochanter, it breaks the neck of the femur, causing avascular necrosis. So the complication here is non-union. It will not form very well. It will not form rightly. Are you getting me now? And also there will be collapse of the head of the femur and sometimes subsequent what? Osteoarthritis. So the next is Coxa vara and Coxa valga. So Coxa vara and Coxa valga, don't forget. In Coxa vara here, there's a decrease in the neck shaft angle. The neck of the femur and the shaft of the femur, there's a decrease in the angle between both of them, and it is less than 120 degrees. Are you getting now? So when there's decrease in the neck shaft angle, this can alter our gait and it could cause limping of the patient. You get it now? So there's a decrease in neck shaft angle, which means there will be inward rotation of the femur. Are you getting now? If there should be a decrease, there will be inward rotation of the femur, and this is seen in femoral neck shaft fracture, and also ricket or slip or upper femoral epiphysis. This is where you can have a decreased neck shaft angle less than 120 degrees, and it can alter the gait, causes limping. And so now we have Coxa valga. In Coxa valga, what happens here? There's an increase in the neck shaft angle, which means the neck shaft angle is greater than 135 degrees, and since there's increase in neck shaft angle greater than 135 degrees, they could predispose the patient to osteoarthritis of the hip. Are you getting that? Also it will affect the gait because there will be wide base of gait because the femur is more outside from the from the joint. You get it now? And also it's seen in osteoarthritis of the hip, healed neck fracture of the femur, and also delay developmental dysplasia. So that's where you can see Coxa valga. So Coxa valga increase in neck shaft angle greater than 135 degree. Coxa vara, you could decrease in neck shaft angle greater than 120 degree. So hope you're understanding it now. So the next one is the osteoarthritis, or which you call it degenerative arthritis. So osteo, which means bone, arthritis, which means inflammation. So when there's inflammation of the hip joint, which means there will be degeneration of the cartilage, there will be the bones will be touching each other, and if there's no cartilage there, the bones will touch each other, and if the bone touch each other, what happens? It will cause bone to bone meeting, which will cause friction when you are moving, because there's decrease in what synovial fluid production. So here there's degeneration of the articular cartilage and the underlying bone. Are you getting now? This causes pain, stiffness, reduce what movement. Are you getting now? So there will be crepitus, presence of osteophyte, subchondral bones showing. So you see in elderly people, trauma, or people with congenital dysfunction, and management is with physiotherapy, medicine, or hip replacement surgery. So there will be replacement of the cartilage that is already damaged. So also, lastly, after osteoarthritis, we also have what we call referred pain. Remember, the pain in the hip is usually referred based on the nerve that is passing through there. So first of all, you can have referred pain on the groin. Are you getting now? On the buttocks, on the anterior hip, which is the anterior thigh, which is because of the femoral nerve passing through. You can have it in the knee. Are you getting now? Because of the sciatic nerve also reaching that area. And most importantly here is to determine and diagnose hip or joint pathology. I hope it all made sense and you have understood everything I've talked about in the hip joint. We started with introducing what the hip joint. The hip joint is between the hip bone, which is the acetabulum of the hip bone, and the hemispherical head of the femur. Then we say that it is tough and stable and transmits the trunk and the upper side of the body down to the lower limb. I said it's the ball and socket joint of synovial variety, and I said that it has capsules, ligaments, bursae, which helps to increase stability, and also it helps in it also contains muscles, which also provide stability to the joint also. So I hope you understood it. I hope you learned from everything I've talked about, and I put it using different steps and different outlines for you to get it. So I've taught you the shoulder joint, I've taught you the elbow joint, I've taught the wrist joint. So now we did the hip joint. So the next one we're going to is the knee joint. So I hope you are here up to now, and one thing I want you to do is to help me to subscribe and turn on your post notification button, so anytime I drop any video you'll be sure to be notified. If you are new to this channel, make sure to invite others so that they'll learn, because we have various important videos that you'll be learning from. So now stick to the end and go to the next video, which is the knee joint. I will see you there. Bye bye.